we will see that how the physiology of that geriatric population is different from the rest of it, and then how what are the things that are actually different, so that how can we tailor our management plan according to their needs. So this is the first part. The second part would be the geriatric assessment, yani history taking and all that. So we will start with that. First, the basics. All right, you guys can see the slide, right?
Yes, doctor.
All right. Okay. So we'll begin our presentation. And this is the geriatric medicine. What age? Why is it important? We have discussed. We'll discuss some of the physiology and some of the pharmacologies. They are different in these aspects also, in order to take consideration into clinical account. So geriatric medicine involves the care patients 65 and older, and we will see here there are different comorbids that are there when you are dealing a patient with geriatric population. He must be having some multiple illnesses. And it has they have unique mode of presentation of illnesses. Multiple illnesses make it like a syndrome, because when you are dealing with all these things, it will actually complicate the situation. And elderly attribute a lot of symptoms to old age and not disease, and marginal reserves. So they just have not very much reserves into their account. So that you need to be very careful while you are managing a patient with geriatric population. Look over here, the patient may have diabetes, hypertension, osteoarthritis, maybe may have, if he's a male, benign prostate hyperplasia, cataract. So he's actually having these issues. But if you combine all these issues, they are all contributing towards a very unique identity, which is called fall. So when you are attempting a when you are coming across with a geriatric population, you need to be very careful, and you need to take all the considerations into account while you are managing a patient. Changes, we will see some physiologies, pharmacologies, pathologies, and some performance functioning, perceptions, positions, and plan. In geriatric population, birth history, childhood at times and history, functional history is of extremely important. So as you see in your pediatric history taking, you take some important aspects like birth history, antenatal history, natal histories, and all that. This is specific for yani pediatric population. Some add-on points for if you observe gynecology, they have some add-on points apart from history presenting complaint. You have some different specific areas where you concentrate on. If you talk about geriatrics, functionality is something which is very important, and collaboration is very important. Detailed drug history is also very important, and the detailed review of symptoms are also very important. And examination, when you're examining it, what are the different functional assessments, and it also involves some special tests which is pertinent to geriatric population. We will see what. So geriatric population is actually rapidly changing, and we have life expectancy is greater, and so that's the reason the geriatric population is now is increasing in numbers. And we'll skip these demographic data. We will concentrate on the clinical aspects of the geriatric population. If you see CNS, the physiology, how the physiology is different. 10% loss of the neurons, this is normal. Demyelination is going on. Delayed nerve conduction is going on. Decreased sensory input is going on. So this is all physiology which is going on in the geriatric population. If you see special senses, from the eyes, lens getting thicker, pupil size reduced, reduced depth perception, and macular degenerations. So you can expect older ages to be to have some decreased or difficulty in visualizing things. So you need to consider this thing also in mind while you're prescribing the things. If you're prescribing it and the adult population is geriatric population is the only one, then you probably need to use big fonts and clear fonts so that he can understand what you're prescribing to them. So this is one thing. The other thing is the ears, wax getting drier. stiffness of the ossicles and the cochlear and central degeneration, and this is the time, this is why they hear a little louder pitch. The taste buds are getting lost, and that's the reason in geriatric population, and they have problems in eating because of the dentation, number one. Number two is because their taste buds are not getting they don't feel the taste of the things. If you go into the CVS, there is arterial stiffness, decreased baroreceptors, decreased conduction, LVH, and decreased blood flow. So patients who are geriatric, you tend to see high blood pressures and decreased baroreceptors. So you probably have, there is arterial stiffness, which actually causes, if you see it in a clinical context, they will cause pulse pressure, high pulse pressure. What is high pulse pressure? The difference between systolic and diastolic is quite high. You can see in geriatric population 120 over 80, 120 over 70, or 100 over 50. So there is a big difference of systolic and diastolic blood pressures. This is because of the arterial stiffness. If you see respiratory, they have weaker cough reflexes, their chest walls become stiffer and decreased elastic recall, and that's the reason they are more prone to have more respiratory tract infections. And when you see in your internal medicine ward, you have come across a lot of patients who lot of older elderly patients who are admitted because of the complicated pneumonias, and their pneumonias are quite severe. The patients are many times in the special units, and this is because they have this physiology going on. And that's the reason we give this population prophylactic pneumococcal or vaccinations to take care of these respiratory problems, because they tend to complicate more. If you see GI, they have delayed dental decay and decreased acid production, gut slowing. So the patient who has more, maybe some GERD problems, reduced absorption of the small intestine, and reduced liver blood flow. So the GI system, if you observe here, it's going to getting sluggish. So you need to be very careful while you are developing a diet plan, or while you are giving some medications which has effects on GI. So they will have exaggerated response. Musculoskeletal, 30% muscle loss, joint degeneration, increased bone resorption, and decreased bone formation, which obviously leads to more osteoarthritis and osteoporosis. In renal, 10% decline in the creatinine clearance, and nephrons are getting decreased and decreased blood flow. So what do you think, what is the significance in the clinical context if there is 10% decline in the creatinine clearance? So why do we need to know that?
For the doses of drugs,
For the
to
doses
adjust it.
adjusted. Okay, so these populations require normal doses, low doses, or high doses?
Low doses.
Low doses. All right. Why?
Because the clearance is decreased.
Because the clearance is decreased, and that's the reason that the drug stays longer in the circulation. The endocrinology, if you see, observe endocrinology, decreased glucose uptake, decreased insulin resistance, increased PTH, and decreased reproductive hormones. Skin is getting decreased, loss elasticities, subcutaneous fats, and all that. Immune system, we have discussed that these patients are relatively more immunocompromised, and because decreased interleukins and declining antibody levels and impaired cellular immunity, so their immune response is weaker. And that is the reason we want to, yani, if you see in COVID-19 patients, we try to first prioritize the geriatric population to get vaccinated, because of the same reason, that they tend to have complicated pneumonias if they develop COVID-19, and they are immunocompromised. Physiology, if you see, CNS, minor forgetfulness is normal. However, dementia is not normal. Dementia is a pathological condition. Special senses में, if you see here, decreased sight, hearing. Serious orthostatic blood pressure drop is an important finding. And in respiratory, you have weaker reflexes in GI, dry mouth, loss of appetite, constipation, and vitamin deficiencies. These are normal physiological effects or the problems that geriatric population can face. This is the revision of all what we have just said. And if you see here, lens thickness, yani wax impaction, hearing problems, smell and taste. This is the physiology, and these are all the clinical things that you can expect to see in geriatric population. So arterial stiffness, as we discussed, widened blood pressure, pulse pressure. Decreased baroreceptor will cause orthostatic blood pressure drop. Decreased conduction will cause rhythm changes. LVH, diminished exercise capacity, so on and so forth. So if one has to say, okay, why the geriatric population has widened pulse pressure, then you should know that it is because of the arterial stiffness, and so on and so forth. So you need to correlate actually the clinical presentations with your basic aspects. Less mucociliary clearance and decreased FEV1, decreased vital capacity, increased dead space. This is all because of the physiology that is going on here. Gut slowing, which will lead to constipation. Reduced absorption would lead to vitamin deficiencies. Reduced liver, cytochrome P450. Reduced in the physical activity and joint osteoarthritis, osteoporosis, decreased clarity clearance. These are all clinical aspects, and you should have the basic explanation or the rationale why the geriatric population has these clinical manifestations. And glucose intolerance, and there's osteoporosis, there's pelvic floor weakness because of all these things going on in the background. Dry skin, they have decreased sweating, nails getting thicker, increased risk and poor response of infections, for example, fever, because of these immune systems. So this is about physiologies. If you talk about pharmacology, there is a difference between pharmacokinetics, pharmacodynamics, and decreased absorption. Absorption, reduced gastric acid and emptying, reduced subcutaneous fat, circulation changes, decreased lean body mass, increased fatty tissues. If you see metabolism, reduced enzyme activity, and decreased plasma proteins, reduced in nephrons, blood pressure, blood flow, decreased GFR. So the patient has decreased GFR. The other thing is the geriatric population has polypharmacies. What do we mean by polypharmacy? The patient is getting a lot of medications for probably for the same conditions, or because he or she has multiple problems, and that's the reason they tend to have 10-15 medications on an average. So it is in itself is quite a problem. And this is why they're more likely to have adverse effects. There are more drug interactions, so you need to carefully review the medication that they are on, and you need to critically evaluate whether they want these medications or not, or you can just skip that. So it's a graph, number of medications taken. So how do you want to prescribe? Rule of prescription is you need to start the patient. If a geriatric population comes to you for anything, for blood pressure, for sugar, for GI problems, for anything, you need to start low and go slow. So you will start with low doses, and you need to go very slowly and gradually. You can tape it, keep it up. And 20% of all the hospitalizations in the elderly are related to drugs they use, because the kind of drugs they are using, they have more prone to have side effects and adverse effects, and that's the reason they get into hospitalization. So as a primary healthcare physician, if you carefully review those their problems, geriatric populations, their hospitalization is going to be decreased. If you observe in your ward, you have gone through internal medicine, you've gone through general surgery, There are a lot of geriatric populations which are getting hospitalized and they are terminally ill. So the reason because if we take care before these things happen, we are going to save them from a lot of complications and from a lot of mortalities. So there is another rule: ask the patients to bring the medications, not just the prescriptions. So you should make sure that what they are eating or what they are taking as a medications, they should know what they are taking, because they many times they have some comprehension problem. They recognize the medications with the names and colors, so that's sometimes confusing. And you can also advise the geriatric population, if they are taking it on their own, they need to make two separate boxes, one for the morning box, one for the evening boxes, and then take one pill out of it, so that they don't confuse and they don't forget that I've taken these medications in the morning or the medication in the night. The other thing is, in the pharmacology, you need to be very careful about all these NTs, because they try to have more side effects in elderly patients. Anticholinergics have anticonvulsants if the patient is on antidepressants, if the patient is on antihistamines, antipsychotics, and benzodiazepines on sleeping pills. You need to carefully review that and try to omit if it is not needed. So all these NTs have a lot of adverse effects and side effects on them. So please try to avoid these medications. If they are taking it, we must have strong rationale for that. They have altered cell receptors, greater CNS effects, and increased nephrology and hepatotoxicity because of these anticholinergics or anti something. So a 75-year-old male presents with fall. What important pertinent information do you need? And what physiological and pathological changes may be contributing to his fall? We are discussing a case. All right. He takes 7 medications, which he takes all together in the AM. Occasionally skips when he can't buy them. What problems you should look at and what solutions you can offer. So this is actually an eye opener for you. If a patient comes to you like this, how are you going to evaluate these patient? So if the patient has fall problem, what thing comes into your mind? What could be the reason for this fall? What could be the possible reasons that you could think of?
Issues in balance.
Issues in the balance. All right. Okay. Why there must be issues in the balance? What is the physiology or pathology or anything that you could think of?
Maybe Parkinson.
Parkinsonism. Yeah. Okay. If the patient is on Parkinson, yeah. Great. All right. Any other things that can come into your
He
mind?
may has osteoporosis.
Osteoporosis. Yes, that's something very significant. So you need to ask the patient whether the patient has osteoporosis or not, has Parkinsonism or not. Anything else?
Arrhythmias.
Arrhythmias. All right. Yes. That can also lead to fall. Good. Okay. Anything else?
Vision issues. If he has
Vision issue.
cataract, for example.
Yes. So visual problems could be one thing that can also attribute towards falls.
It could be diabetic.
Could be.
Diabetic patient, complication of diabetic.
Yes, that could also lead to fall. Yeah. Could you think of any drugs that can lead to fall, and why?
The drugs that cause orthostatic hypotension.
Drugs that cause orthostatic hypotension. Yes. Someone was saying from the male side.
Drug doctor like antipsychotic.
Yes. Antipsychotics or vasodilators, as you mentioned, benzodiazepines like sleeping pills. So you also need to actually define or describe the patient, what could be the reason for the fall. by asking these questions in your history, and then you can come on to the diagnosis that what is the reason for his fall. So the basics for the geriatrics from this presentation, the take home message is the basic of the geriatrics, how they are different from different systems, and what are the clinical manifestations of these physiological changes that we observe in the geriatric population. Anything needs to clarification for this? Is it clear?